Most of you will be familiar with the immobilization mask systems. Most of you will have been treated on this kind of a linac, the Versa HD, which has the main radiation comes out of here, and then these things on the side are a very basic CT scan image. And as you know, most people, they'll be lying on the couch, and this will just slowly rotate around you as you're having your treatment. So this is the planning scan the CT scan we did to work out the treatment. This is a CT scan that we've done on the actual linac when the patient's having their treatment. You can see it's nowhere near as higher definition, but what we're doing these scans to make sure we're treating exactly the right area. So they do this every day. When you're having treatment, they have when a patient's having treatment, they'll have a CT scan on the machine every day, make sure the treatment's exactly in the right position before everything starts. And quite often during treatment, a lot of our treatments are going on for a few weeks. Patients will lose some weight, the tumour will shrink. So this is the original CT scan. This is a repeat scan which has been done about halfway through the treatment. And you can see on the repeat scan the body's contours got a bit smaller. So that's showing the patient's lost a bit of weight. And the tumour's actually got smaller as well, which is showing here. So we do a scan about halfway through, and then we often will adapt the radiotherapy plan because the patient's lost a bit of weight and the tumour shrunk a bit.
Does that weight loss that you see impact the accuracy of the radiation?
Yes. If you're going to continue with the same radiotherapy plan all the way through, it could mean that there's a higher dose to the normal tissues because they've lost a bit of weight, or possibly the coverage of the tumour is not quite good enough. So we're adapting either because we want to make sure the tumour is treated properly, or because to keep the normal tissue doses okay. So it's quite common for the normal tissue doses like this salivary gland, the parotid, the dose to go up as they lose weight. So that's why we're doing that. I'm one day a week at the university, so I'm going to tell you a little bit about a research project that I'm hoping to get off the ground. MSD provide Keytruda, which is a form of immunotherapy. It's a immune checkpoint therapy. Keytruda and some of the other drugs like this are showing that they work really well in advanced patients, or advanced patients where the cancer's recurred, or it's spread somewhere else in the body, and there's an increasing role for looking at immunotherapy like that, which is currently not funded in public hospitals, but there's Pharmac is going to be looking at the question of funding for immunotherapy in head and neck cancer, I think, within the next few months, hopefully, so we might have some change there. One of the things with immunotherapy is that, so it works well in some patients with advanced cancers where it's spread. What about using it up front in the main treatment? And there have been several studies that have been done, and generally all of these studies have shown that if you combine immunotherapy with standard radiotherapy, it doesn't work well. And the reason we now understand why that is because there's this conundrum really that when we're giving radiotherapy, or when you're having surgery, we often treat the lymph glands because they need to be treated. If you don't treat them, the risk is that the cancer will come back there. But the lymph glands are what is needed for immunotherapy to work. So one approach to get around that is to give the immunotherapy prior to your main treatment, when the lymph glands are still intact. And this is a study in a journal called Nature Cancer, and it was showing this study in head and neck patients where they gave immunotherapy. It wasn't Keytruda actually, it was another immunotherapy drug called durvalumab, which is sort of similar. And they combined it with a very focused type of radiation, which was just treating the cancer, but they weren't treating the lymph glands in the neck. And this picture on the left is showing a slide of a biopsy of the tumour before any treatment started, and this is all the cancer here. And you can see a little bit of these sort of starry sky, purpley kind of blacky things in between, which are the immune cells, but there's not that many immune cells there. So they had this focused radiation plus the immunotherapy, and then they went on and had surgery several weeks later. And when they had the surgery, then they removed the lymph nodes, because you have to treat the lymph nodes. But you've given the treatment beforehand so that the immunotherapy can work. And so they took the tumours out when they did the surgery, and you look at it here, and you can tell that this image and this image are very different. And the difference is all of this blacky, bluey, greeny things is immune cells that have gone whoosh into the tumour, causing an immune response to kind of fight the tumour. So this was a pilot study looking at that approach of giving a kind of treatment before surgery with a very focused radiation plus immunotherapy, and it led to phenomenal results. So these patients were doing really well, and there's now a follow-up study that's happening. So we're really interested by this kind of approach, using a drug that was developed here in Auckland. It's a drug called taloxotinib. So with tumours, as the cancer grows, it's got to grow its blood supply with it. And often that blood supply within the tumour is much more chaotic and disorganised than in normal tissues. And so it's quite common for tumours to have areas where the blood supply is not quite meeting the demand of oxygen and nutrients and stuff. And so parts of the tumour become low in have low levels of oxygen because they're just not getting sufficient blood flow through them, and that's called hypoxia. So hypoxia is when you've got parts of the tumour which have low areas of oxygen, and this is a particular problem in head and neck tumours, and hypoxia generally makes tumours behave more aggressively. The hypoxic part of the regions also don't respond well to conventional chemotherapy or radiation very well. So this drug, taloxotinib, was developed just across the road in the Auckland Cancer Society Research Centre, and it targets the hypoxic part of a tumour. So this is just showing a slide with this is actually a mouse tumour, and the blue is the tumour, the green is the hypoxic part of the tumour. They're given this drug, and this drug is, the red is showing where it's active. It's active in the hypoxic part of the tumour. It doesn't have much of an effect, this particular drug, in normal oxygenated tissues, which is really good because it means it doesn't have a lot of normal side effects, because normal tissues are normally well oxygenated. So it's a drug which targets tumour and doesn't have too many side effects, and helps with this problem of hypoxia. And we're going to be we're hoping next year and the year after to use this drug in head and neck cancer patients. So it's going to be patients who have HPV unrelated tumours who are planned for surgery. So surgery is going to be their main treatment. And this is kind of showing you what we normally would have done. They've had their surgery and they're getting radiotherapy. So this time just to the one side of the neck. We're going to be using a very focused form of radiotherapy called SBRT, just treating the main tumour, not treating all those regional lymph nodes. So you can see this way smaller. It's just a much tinier area that's being treated. We're going to be giving SBRT with this drug taloxotinib and with a form of immunotherapy. Just 3 doses of radiation. So instead of having several weeks of radiation, it's just going to be 3 doses, but to it's quite a high dose each time, but to a very small volume. And then they're going to go on and have their surgery. But the real benefit of this is that if they have surgery, we anticipate most patients will not then need to have post-operative radiotherapy. So they're going to avoid having the radiation to all of those large areas. So you can imagine, I mean, if you're having treatment down here, you know, yes, you're going to be treating your voice box, you're treating your thyroid. If you're having this type of radiation, you're a long way away from that, and so you don't have the same sort of side effects. So this is kind of where I think over the next 5-10 years, I think we are likely to see things moving where potentially we are going to be giving treatment to a very focused radiation to a very focused part of the tumour, combining it with immunotherapy and potentially other drugs, then going on to surgery and hopefully avoiding that really large volume radiation. So initially it's only going to be done in clinical trials, and this particular clinical trial, it's probably going to be 2025 where we get this up and running in Auckland. Similar sort of studies are happening in North America. So outside of those kind of very small clinical trials, the standard is very much just what I've been talking about, but I think this is where things will potentially move in the future.